Very brief talk about adjunctive techniques, additional tests that we can use for fetal monitoring. Yeah, I have a couple of people online. Most of you are muted, so please feel free to unmute yourself and ask questions or answer questions. And I have 3 people that I have kept in the room here for torture. Yes, managed to secure somebody to torture today. So, why do we need adjunctive techniques? Why do we need any additional tests? We're happy with physiology. We're happy that we can figure out what the baby's up to. We're happy that we can figure out the baby's well-being. Why are we asking for additional tests? So all the information, all the tests that we've had regarding CTGs are always dated from the previous pattern recognition era. So unfortunately, all the new figures that we need to come up with have to be redone based upon physiology. However, this is the information that we have so far. Basically, that we have increased our intervention rate, so 63% more cesarean sections with just CTG interpretation, 15% more assisted vaginal deliveries with just CTG interpretations, and we haven't actually achieved any improvement in outcome. Nowadays, with physiology, we have seen an improvement in outcome, but we still have not improved the intervention rates. Intervention rates are still quite high. So the whole point of additional tests is to try and make it a bit more specific so that we are intervening when we need to, a bit more sensitive. Okay, so we're intervening when we need to, and very specific or more specific, so we're not intervening if we don't need to. Yeah? Okay. And as I said, we can provide reassurance to ourselves just by looking at the baby's baseline and variability. If the baseline variability are stable, baby is fine. Okay. What additional tests are we going to be talking about? And the idea to try and make this a little more interesting. So we're going to start off by computerized CTGs, Dawes-Redman. We use all the time. I'm here to try and explain some of the entangled names and nomenclature that we can use. Okay, fetal scalp stimulation, when to use it, and scan, a very brief touch upon. Okay. Any test, whatever the test is as good as the question you're asking and with the interpretation to the answer that you get. Because if you're not asking the right question, you're very likely not going to get the right answer. If you're not using it at the appropriate time, you're going to get a wrong or misleading result. And that's super important. You are the monitor, regardless of the additional test. I'm not happy to hear that Dawes-Redman is fine, it's ticked, so it's okay. Stan is happy, so I'm happy. And I've used to hear that so many times. It basically means that you don't understand the machine or the test that you're actually applying. Okay. Let's start off by Dawes-Redman analysis. What is Dawes-Redman analysis?
An algorithm looks at doing quite how it works.
Yeah.
But it looks at sort of short-term variability, like lots of different things, and based on that decide. And it looks at baby's movements as well, and based on that decide whether it's okay. I'm not 100% sure how it works.
Okay. So, but in all essence, it's actually a computerized analysis of the CTG. Yeah, it's a computer assistant. What it's trying to do is trying to take your CTG, compare it to 100,000 CTGs in the past, okay, and over a lifespan of about 35 years that they've started this, okay, and trying to come up with, does this fit with most other 100,000 traces? Okay, when can we use CTG, Dawes-Redman analysis?
Antenatal, but not, not in labor.
Why not?
Because the contractions, that changes the setting completely. I mean, it's not been checked in those. This is zero, assuming. The ones that the 100,000 are probably also antenatal CTGs.
Okay. Anyone have any better understanding or reasoning behind? Why are we not using it in labor? So that's where I say, if you ask the wrong question at the wrong time, you will be misled by the answer. So Dawes-Redman analysis is basically comparing your CTG at rest to 100,000 babies' CTGs at rest. It's not comparing babies' responses. It's not designed to look for babies' responses. The only response it's designed to look for is response to movement, possibly. Okay? It doesn't necessarily link the the accelerations to the movements and how is this a sufficient acceleration, etc., as much. Although there is an element where it looks at it, but it's not very specific to that. If you are trying to figure out whether this baby is well with hypoxia or with the hypoxic events, so the contractions, the cord compressions, this is not your tool. It's not designed to look for that. Okay? So that's the very big limitations, which is why here comes the gray area. So I am inducing someone, they're just about contracting. Can I use it? Can I not use it? So can you use it? Can you not use it? Because I've heard as many answers to this question as the many number of times I've asked the question. Yes? And everybody's trying to make it fit somehow or another. Asking Professor Redmond himself, he had 3 different answers to the 3 times I asked him the same question. Okay? Because every time you ask the question with an additional scenario and you get the different answer. Again, this test is designed to test the baby at rest compared to 100,000 babies at rest of similar gestational age if we can. Okay? And again, if we can. It's not designed to test babies' responses. It's not designed to test babies' reserves for contractions and hypoxic events. So you can't use it if the baby is contracting. Okay? Because whether the baby is responding or not, the dose-Redmond is not going to pick that up. It's not expecting responses as much. It's just expecting the baby to wake up and fall asleep. That's all it's expecting. So if the baby's awake all the time, the baby's not getting any cycling anymore, okay, it's not going to pick that up. If the baby, as in it's not falling asleep anymore, it's not going to pick that up, even though that is actually gradually evolving hypoxia. Right? If it is not responding to contractions, it's not going to pick that up. It's not going to recognize that this baby is not responding to stimuli because it's not picking up the stimuli. So it is comparing rest to rest, not activity. So you can't use it with uterine activity. Does that make sense?
Yeah. What about if there's just kind of some tightenings on CTG from approximates or something like that?
So if it's just about tightenings, you're barely palpating them, you can. Okay? But if you are in threatened preterm labor or she's feeling contractions, you shouldn't. Okay? There was an incident when there was a baby that was, well, we were criticized whether we're using it appropriately or not appropriately because she came in a couple of hours ago with threatened preterm labor, even though she's not contracting right now. This baby passed away a couple of weeks later, not even the same day. And then they criticized, well, you used dose-Redmond incorrectly 2 weeks ago. Well, not entirely clear on that, but that's where it got us into problems, even though we don't think that actually affected anything personally. Okay, so what is the machine actually looking for? It's looking at the trace and it's assessing the trace for many things. Starts off by looking for the things that we look for on a trace. So how much percentage of the time do we actually have contact? So if we have a lot of loss of contact, it will alarm saying I have too much loss of contact. It's not going to meet the criteria. Okay. It's looking for contractions, obviously. It's looking for baby's movements, and it calculates that per hour. So if you have somebody who's coming with reduced fetal movements, she's had a 10-minute CTG trace, and she has 2 movements on there, and then you read, well, it's saying it has 12. It didn't pick up 12. It's estimating that if we carry on, this is likely to have 12 movements within the next hour. Right? Even though all you could see was 2. Accurate or not, well, the reality is that the most the baby is going to move is the moment you start stimulating it. Okay, so the moment you put the trace on, you're going to feel more movements. It may be that this lady the baby's not going to move any further, and that's only the 2 movements that you get for the entire hour. But that's the caveat. That's what it reports when it says 12 movements. It's per hour. Okay. Movements per high and movements per low. So the number of movements in the episodes of high variation and the number of movements in low variation. And that's where I'm saying it tries to look at accelerations / activity when the baby is, or it's perceiving that baby is awake. However, that has no implications on whether it's meeting or not. So the fact that it's completely flat and not moving, okay, and then it has what it perceives as a movement, or the woman perceives as a movement, the fact that it just happened in a high variation, that's a happy thing. Whether it's a true movement or not, it's not going to be as accurate. You are the monitor, remember that. Okay. Basal heart rate. How do we calculate the basal heart rate?
the mode. Just by looking at it, you can tell quite easily. I don't have it.
So how do we, just by looking at the trace, how do you calculate what the baseline heart rate is?
It's where it seems to be settling most of the time.
No acceleration to make decelerations. It's staying alright.
Yeah.
So you're gonna block out all accelerations, all decelerations, and all episodes of high variability. So that's how we assess that. And we take the rest and we draw lines through it where it's most fitting. But that's not how the machine calculates that. So it takes away the decelerations. Doesn't necessarily take away the accelerations, okay? And it doesn't take away the high variation episode. So when there's increased variability, it doesn't take that away. It's gonna calculate the entirety of what's left after removing the decelerations and give you a number. And you will notice frequently that if you actually go and look at the number that it's giving you and the number that you are estimating, they are different. Which one's the correct baseline?
The one that we say.
The one that you say, not the one that the machine has calculated. Okay?
The other one says Jules Redmond can't be criticised. Better than the human eye.
No, very wrong. That's very wrong. Dawes Redmond is a test. A test is as good as you use it. Okay. Now, the other thing the machine does not look at is where is the baseline compared to this baby, simply because the machine has no idea where this baby's baseline was yesterday or last week or the week before. It's going to calculate to the 100,000 traces of the entire human population that it has recorded, which means that the baseline is not going to be very specific. So the person who's actually going to say that this baseline is appropriate, again, is not the machine, it's going to be you. The only time the machine is going to alarm if the baseline is over 160 or less than 110. That's the only inappropriate baseline for it. Otherwise, it will not alarm. So once again, who can assess the baseline? A, the machine can't even give you a correct number. B, it doesn't even know where it's supposed to be. So again, it is you, okay, not the machine. Okay. Accelerations. Now, the machine is supposed to be assessing the entire human population. And it's supposed to be assessing from 26 weeks to 42 weeks. Okay. So the definition of an acceleration is... Hello? Was there somebody else a question? No. Okay. So I was saying that we assess an acceleration differently according to gestational age. So a 26-weeker, I would accept a 10 beat rise for 10 seconds for it to be an acceleration, but I wouldn't accept the same for a 38-weeker or 39-weeker. However, because it's a computer that's trying to figure out what's going on, it has one cutoff for all. So the reality is it's going to calculate an acceleration or accept an acceleration if it's just for 10 beats for 10 seconds. Okay. I have not tested and I have not actually asked the question, does it have to specifically start from the baseline and come back to the baseline? Or can it pick up shouldering as an acceleration? My personal impression from my experience with the machine is that it can pick up shouldering as an acceleration. However, I haven't gone back to ask Professor Redmond that.
Okay. Would you ever get shouldering in a non-labouring?
Well, if there is activity that you can't see. Yeah. Because not all activity you're going to be able to pick up. Sometimes the cord compressions are happening because there's oligohydramnios and the baby is literally leaning on its cord rather than a, yeah. Okay. But again, if it's marking S accelerations, don't take it with, you have to go and actually see the accelerations. Okay. Decelerations, it's actually a lot better at picking decelerations than potentially even us, with the caveat of the shallow decelerations. And I'll explain why, because the way I'll tell you how the machine looks for decelerations, and you'll see where the decelerations, the caveat comes in. Okay, but when it looks at decelerations, it actually classifies them into small decelerations, so less than 20 beats or more than 20 beats. And it's talking about not 20 beats as a drop of 20 beats, it's talking about lost beats. And we don't understand what that means, because that's completely different from signal loss. I will explain that in one tick. Okay, it looks at episodes of high variation, it looks at episodes of low variation, which basically to us, it means normal variability and reduced variability. High variation is when variability is more than 5. Low variation is when variability is less than 5. Okay. So if it's telling you that there's no episodes of high variation, it's basically telling you that generally the entire variability of the trace is low. Okay. If it's telling you that there's not enough high variation, it means that the baby has not woken up for long enough for the machine to consider that this baby is active and happy. Short-term variability is a completely different concept, and we will talk about that, and it's only expressed in milliseconds. You can only describe short-term variability in a trace of 60 minutes. You're not allowed, even though the machine prints it, you're not allowed to assess short-term variability in traces less than 60 minutes. Okay, let's look at what lost beats means. So this is a CTG trace. The machine is going to look at that trace. It's going to take the average heart rate and say, well, that's my average heart rate. So I am expecting that this baby is beating at 140 beats per minute. So for every minute, I'm expecting 140 beats. Now, what happens is every minute, what it does, it calculates or counts the number of beats per minute. And then it's basically seeing how many beats is it missing. So in this deceleration, it's counted here 140 beats up until this point, and then it has lost, right? Because the heart rate dropped to 100, it's missing 30 beats. It only counted 110. Here it only counted, or it counted 90. Okay, so here it lost 30 beats. Here it lost 40 or 50 beats. Here it lost 20. And based upon that, then it starts categorizing decelerations into bigger and deeper decelerations. It depends upon how many beats it has lost. That means that decelerations can be deep or prolonged, and they will count pretty much the same. Because in this episode of time, it has lost 50 beats, while in this episode of time, it lost 30 beats, and in this episode of time, it lost 30 beats. So to the machine, these are both the same. Okay? Be very, very careful of that. Okay. So the less than 20, more than 20 beats makes difference when we're talking about shallow decelerations. Okay. However, for you to get less than 20 beats, you need to have a heart rate that's actually less than 20 beats per minute for an entire minute, while we are counting decelerations 15 for 15. So if you drop a heart rate by 15 beats per minute, short drop, 15 beats for 15 seconds, you're only going to miss 4 beats. Does that make any sense?
Yeah.
That means you are more sensitive in picking up decelerations than the machine. Does that make sense?
My eyes are better than the machine.
Your eyes are definitely better than the machine. Okay? So the good thing about the machine is picking up something called short-term variability. And we don't even know what that actually is. Okay? That is the big problem about Gauss-Redman. We don't really understand the test. So the test is comparing an overview and then a very specific figure. What is short-term variability? Does anyone have any idea? We don't really understand it. Okay. So the machine takes the entire 60 minutes and it divides that into sections of 3.75 seconds. And why 3.75? Why 4? I have no idea. I could not find the answer to that. So why not 4 seconds each? Yeah. Why 3.75? I don't know. What it does is it actually plots the beats over those 3.75 seconds. And what it does, it calculates the difference in milliseconds between each beat. Now, that's how the machine is giving you a rate. Because so this beat to this beat is 420 milliseconds. So I'm estimating that if I carry on beating at this, I am getting a rate of 100 and, I don't know. So that's about 135. Yeah. Okay, and that's about 136, etc. Okay, so it plots all the beats and the spaces in between. And then it goes and sees, okay, what's the difference between those? And it calculates the difference between this to this, this to this, this to this, and it averages that out. And then it takes all the segments of the 60 minutes and takes the average of that and displays it. Looks like a complicated process.
Yeah.
Okay. Sorry, it's good that the machine does that for us. Okay. The problem is, so what do you think would affect that?
movement.
baby's movements.
Okay.
Yeah.
Gestational age.
Okay.
So
The reality is, if you have 5 minutes of activity, that will increase your short-term variability. Okay. If you have, so you need, if you have an entire hour with only 5 minutes of good activity, you have a normal result, which says, okay, well, even short-term variability, even though it's the best criteria from Dawes-Redman, it has to be taken with a pinch of salt because you need to reassess the trace.
Can I ask a question?
Yes, please.
So if, for example, if the CTG meets the criteria, let's say in 15 minutes, so we cannot really comment on short-term variability because it hasn't analyzed it for 60 minutes.
Yeah.
So we can't really take it into consideration.
So you can't take it at all into consideration. You need the 50 minutes.
Okay. All right. Thank you.
Because of the caveat, because as I said, 5 minutes of a 60-minute trace would mess up your numbers. The reality is, if you have 5 minutes that you remember, the moment you put the baby on a CTG, you're stimulating that baby. You get 5 minutes of a bit of activity and then a completely flat trace for the rest of the 60 minutes. But if you're only looking at the 10 minutes, those 5 minutes have given you a reassuring figure when actually this baby is not well.
So we have to actually wait for 60 minutes in order for us to say all the criteria met.
Yes.
And we shouldn't kind of like wait until it ticks the dot and then we say, oh, it met the criteria.
So that's the caveat of Dawes-Redman. So when you're doing a 10-minute trace, the machine is not taking short-term variability into consideration at all. It's printing it, but it's not taking it into consideration. Now, the minimal time for the machine to assess a trace is 10 minutes. After 10 minutes, it comes up and says, have I assessed the trace? And it's only looking for not the entire set of criteria, but 12 points.
Mm.
So it's going to start off by looking whether the baseline heart rate is within the normal range. Okay? But we know that baseline heart rate that the machine calculates is not accurate for this baby. A, it's not an accurate measurement to start with, and B, it does not take into consideration what this baby is doing. So the reality is, I need to take the baseline with my own interpretation of what's normal for this specific baby. Okay. Large deceleration. So it's looking for large decelerations. It's not actually looking for the shallows, okay, or the very briefs, because remember, it's not going to even pick that up. We can see that. The machine can't yet. Okay? Okay. No episodes of high variation. So the trace is completely flat. Okay? So all it's telling you within 10 minutes, that within the 10 minutes that you've assessed, this baby has shown that it was active. Is this just a response to the putting me on the CTG, or is this an actual long-term response? It can't tell you that. Okay, so no movements or fewer than 3 accelerations on the trace. Okay, again, within an hour. Remember, we need 2 accelerations for an antenatal CTG to be normal. Antenatal CTG cannot be normal unless it's had 2 accelerations on it. That's a minimum. 2 accelerations in 40 minutes. That's why the 3 in 60. Okay. And remember I said the machine takes 10 beats per 10. So if it's a term baby, if it's saying there's accelerations, you need to go back and look at them yourself. You need to agree with yourself that these are proper accelerations. Okay. Baseline fitting is uncertain, basically saying you have an unstable baseline. Short-term variation is less than 3 milliseconds. So it's basically saying it's completely flat. Okay. Possible error at the end of the recording. I don't even know what that means. It just says at the end something went wrong. Okay. Deceleration at the end of the recording. Yeah, maybe. High frequency sinusoidal rhythm. And that's where it's alarming all the time. It's talking about sinusoidal rhythm all the time. And we look at the trace, there isn't any sinusoidal rhythm there. But that comes from the short term, the calculation with short term. It's basically telling you that what it can see in the tiny bits in the sinusoidal. How specific is that to the actual sinusoidal? I don't know. I have never, sinusoidal is really, really rare. And yet the machine talks about it all the time. So I don't know. Okay. Suspected sinusoidal rhythm, long-term variation in high episodes below acceptable level, basically saying that even though there has been episodes of increased variability, it's not long enough. Okay. Or there's no accelerations. At 10 minutes, the machine is going to tell you it's happy. or not. If it's not happy, it will keep on checking every 2 minutes. So it can either, and every 2 minutes, it can take away the decision that it said previously that it's happy. Okay, so how do we treat this? This machine can change its mind from 12 to 14. Okay, can change its mind from how am I supposed to trust Dawes Redmond? It's all about taking into clinical context. Why am I doing the CTG? Am I doing this because she's saying I'm concerned about baby's movements, or I think this baby is actually not well, in which case I actually need 60 minutes because I need the best criteria that I have, which is the short-term variation. Okay? Because the short-term variation, if you look at it, it's taking you the entire trace and how much its variation is within the entire trace, not just an episode of good activity that lasted for a couple of minutes. Okay, does that make sense?
So do we need to be doing, if we go see, like, for something around DAU, if I have a woman with reduced movements, ongoing reduced movement, really I should be getting the.
You can see that the baby is very active for the first 10-15 minutes.
Yeah.
The baby is most likely fine.
Okay.
But if I am worried about this IUGR baby who's coming with reduced fetal movements, I would
Yeah.
definitely wait for the 60
An hour,
minutes.
okay.
Right? Just don't most of the time the trace meets in 10 minutes and then it doesn't meet at 60. Which basically means that you stimulated the baby, it responded for a couple of minutes, and then it fell asleep and stayed asleep because it can't respond anymore. Just be careful of that caveat.
Okay. Midwives always like, I want next at 10 minutes, but I wasn't there to take it off.
The reality is that this is the advice that comes from the manufacturer. If the trace meets it's okay for you to take the machine off. But remember, it has to go into clinical context.
So if we're just doing a quick 10-minute CTG, there's no point in doing
No, that's not what I said.
Because you just said.
So I'm saying somebody's coming in, we're going to induce them. Okay? So I want to see whether this baby is active and whether this baby is happy or not. Okay? I am happy to do a dose for 10 minutes because it will tell me whether there's a bit of cycling, there's a bit of activity, that tiny bit of stimulation has responded and the baby's active.
Yeah, but if you can see that with your eyes.
The idea is that you can be medically legally, you're more reassured by having a tick there. And the reality is it does look at cycling. Right? So when we talk about lack of cycling, there are two very separate scenarios. Okay? So lack of cycling means no. You can see it in chronic hypoxia, but that's not what it actually means. Okay. What does lack of cycling mean? Yes. Yeah. So baby's stuck in one of the phases, either completely asleep all the time or always awake. Okay. So and that's obviously they're very different. They're very, very different. So a baby that's always asleep is a baby that I'm always going to be worried about. A baby that I can't wake up is a baby that I'm always concerned about. A baby that's always awake, I need to figure out why. Because a baby in labor that keep on squeezing its cord, I'm not really giving it a chance to fall asleep, am I? I am stimulating that baby's brain every time it tries to even think about falling asleep. So that baby is going to be awake all the time. Is that good or bad? Imagine that every time you're trying to fall asleep, I poke you. Not ideal, but
it makes sense.
It makes sense.
Like I would do the same. So,
yeah. But if you are being stimulated again and again and again, and you just are not responding, is that good or bad?
That's really bad.
That's really bad. So Dawes Redmond criteria is really good at picking up the baby that's active, and the baby that on a short glance is not really active. Okay. So if you want to get an induction of labor going, then Dawes Redmond is definitely going to help you because it's going to show, yeah, that baby's active, it's fine, carry on. Or no, that baby is asleep, wait for it a little bit longer. Okay? Does that make sense? So here it's very helpful. Yeah. The lady that was coming in because she's hypertensive, she's on treatment, we're doing the CTG because we're doing the CTG. 10 minutes of CTG is telling you that this baby is active and responsive. Yeah. That's good enough. I've got no movements, it's fine. I wasn't actually concerned about the movements, I'm just doing as an extra check. But the baby where I'm coming to for daily CTG assessments or twice a day CTG assessments, that I am worried because this baby's IUGR and I'm trying to time when I'm going to be delivering that baby, because every 6 hours actually counts for this baby. I definitely need the entire 60 minutes, I need the full assessment. And to put that into my own clinical context of the things that where Dawes Redmond does not help. Does that make sense?
Yeah.
You guys online? Am I still making sense? Is there anyone still online?
Yeah. It's
Pure
making
Homer.
sense. Yeah.
It's just pure Homer. Everybody else has run away. Thank you. Okay. So running really quickly about fetal scalp stimulation. We talk about it all the time. When is it helpful? What is the idea behind fetal scalp stimulation?
There was one like you mentioned. Oh, sorry.
Yeah. So we assess three parts of the baby's CNS or baby's brain. Okay. Autonomic, so sympathetic, parasympathetic, and the somatic. Okay. The one that protects and responds in labor and in all sorts is usually the autonomic. Okay. The somatic is the higher function one, is the one that you can only use when you're in luxury, when you're absolutely fine and everything is going well and there's no concerns there. So if you have any doubts about how well this baby's brain is functioning, stimulating the somatic part of the brain can reassure us whether this baby's brain is in a good condition or not. Okay. So the idea is that you're going to stimulate the baby to give us a somatic response. So what does somatic response mean? What stimulates a somatic response from a baby?
So when we do it, like
from you,
so
what stimulates a somatic response to you personally?
Just walk around or
So movements or activity.
and we do it.
Okay. Tactile, so touching, pressing. Or emotional, feeling warm and fuzzy. You start feeling all emotion, you get all somatic responses. Yes? So we can't really make the baby warm and fuzzy. But we can observe the baby if it's moving, or we can stimulate the baby so we can poke the baby. Okay. Other ways of poking is by creating loud noise. So we can digitally stimulate this baby, okay, or we can use something that causes pain, which is actually how fetal stimulation was actually designed. Please don't use that as a first resort. Or we can use it with sound, which is where Dopplers and ultrasounds or a high-pitched sound of some sort. I mean, this was actually designed on the electronic laryngoscope, larynx, the electronic larynx. But no, you put it on mom's tummy and that stimulates the baby because of that noise. That's how they tested it in research. But an ultrasound machine works and a Doppler machine works. It creates that high-pitched noise. The easiest one is always digital stimulation. How far dilated does the lady need to be for you to be able to do a scalp stimulation? Okay. So you can wiggle the baby up from the top. You don't need to stroke its head to start with. And even though it's called fetal scalp stimulation, you can literally stimulate the baby from anywhere. And if you actually want to stimulate the baby's head, you don't really need to put your finger through the cervix at all. You can do it through the vaginal wall, as long as you can feel the cervix, the head. Sorry. Does that make sense? Yeah. So she doesn't need to be dilated. And even more easy, you can use the ultrasound machine that creates a bit of noise. That's why women that come saying I've had reduced fetal movements, you put them on the CTG machine and the baby's all over the place. It's not because they were lying, it's because your doctors have actually just woken up the baby. Yeah? When would you use this? Try not to cheat. I know it's on the screen. Try not to cheat. Go on, guys. When would you use it? When would it be most helpful?
We do it a lot in labouring women when they've got, traces that you're worried about, say there's a high baseline, you're worried about reduced variability, perhaps of choreo or something. You want to see if this baby's still okay. So we did that yesterday, stimulated the baby. It was one that's got the reassuring sign in that baby. So basically, when you have lack of responses. Okay, so if you are worried whether this baby asleep or is it unwell, okay, I would start thinking about stimulating this baby. Okay, so let's describe a CTG and tell me when that scenario looked like. just kind of like what I've just said. So, so there's no cycling, maybe.
There's no cycling,
Um,
as in baby stuck in wake phase or sleep phase.
well,
No cycling means both, so you
yeah.
have to
So
specify
sleep
which one.
phase
Sleep phase,
is
so
what
it's
we wanna
reduced
figure out.
variability and okay,
Yeah.
no responses. Where's the baseline?
So it could be high, or it could be, well, it would just be normal, you'd imagine.
Okay.
Could be high, like when yesterday was high. So then you're more worried about this baby.
So if the baseline is high, do you think this baby is going to be fast asleep?
No, it's like this is adrenaline.
So if the baby is high, if it's high because there's adrenaline release, you will never fall asleep with the baby with adrenaline rushing through your system. Okay, you will never fall asleep yourself. You will be shaking. You will be wide awake. So a reduced variability with a high baseline, that's not a sleepy baby. That's an unwell baby. The baby that you're thinking of, is this baby okay or not? Is this baby asleep or is it unwell? Is the baby that I'm suspecting it's asleep. So that would have a normal baseline, or actually slightly lower than what it normally is because it's asleep, okay, with reduced variability. Not for the baby that has a high baseline with reduced variability. That baby is unwell until proven otherwise. Does that make sense?
Yeah, that makes sense.
Yeah. Stimulating that baby at a high baseline, even if it does respond and wake up, that baby's not happy. Something is still making this baby tachycardic. This used to be an okay thing when we used to say there's uncomplicated tachycardia. There is nothing uncomplicated about tachycardia. Yeah? So high baseline doesn't need scalp stimulation. It's the normal baseline or slightly lower baseline with reduced variability that you can employ scalp stimulation. Does that make sense? Okay. You're anticipating that you're going to find a bit of acceleration and then normal variability for a bit. Not just poke acceleration, then flat again. That's not a baby that's woken up. That's a baby that you probably just hurt a bit with your poking. You poked it a little bit too hard. Okay? It literally just stirred and then fell back. Yeah? GCS scale. Imagine you're in A&E and you've poked somebody and they've just moved their arm. That's the tiny acceleration flat. Okay? Because that person is not conscious. The person that you punches you in the face and then it's actually shouting at you and it keeps on shouting, that's a good person. Yeah? Does that make sense? Okay, so if you actually get an adequate response, the risk of this baby becoming or being hypoxic is less than 2.5%. But if it doesn't respond, the risk of it being hypoxic is over 38%. So this baby is very likely unwell or hypoxic. Okay, especially if the reduced variability continues and if there's actually shallow T cells as well with that. Does that make sense? Okay. Humera, do you have any questions about that?
No, it's clear. It's very clear.
Cool. Obviously, we've talked so many times about Stan. Does anyone have any questions about Stan? Should I start asking? So what's Stan? What does Stan stand for?
It's just ST segment analysis, actually. So what is
ST segment analysis.
I was like, I can't think of what the N stands for.
ST segment analysis. Okay. So basically, it is calculating. It's looking at the CTG as a whole and the ECG signal, and it's comparing the ECG signal for that baby to itself. Okay. And looking for changes of the ST part of the ECG signal. Okay. Because that's the part when the baby supposedly at rest is recovering from the contraction, from the cardiac contraction. Okay. When is Stan important? Again, it's a test, so we need to say when we're going to use it.
It's only helpful in an abnormal CTG. It's not, you ignore it in a normal CTG in labour.
Tell me more about that.
So, because sometimes the Stan, it comes up with a, biphasic or something, but you've got physiologically normal CTG, in which case you're not going to intervene just based on the Stan. But if you've got an abnormal looking CTG and you're perhaps more worried about it, but maybe if Stan's not enough, you know that the myocardium's okay, so you can probably keep going with the labour at that point. It's only the abnormal CTG where you would.
So you're saying it absolutely correctly, but you're missing a few things. Bits. So who is this test suitable for? Let's start there.
Oh, okay. So normal healthy baby.
Normal healthy baby,
beyond
36 weeks or more,
Yeah.
because that's what we've tested. Okay, that we are picking an ECG signal for, so we need to have an FSC on. Okay,
So they already can't have an FSC for the reason.
if you can't have an FSC, then you can't have a test. Okay, you're comparing, and you're comparing it to itself. Yes.
Yeah.
So you're comparing it to itself. So you need to have enough time to actually determine what's normal. So you need to start at a normal point, have enough time to determine a normal point, and have enough time for it to become abnormal and show the changes. So if you're starting from an abnormal point, so somebody who's already hypoxic, you can't test it. Okay? If you're starting with somebody who's deteriorating really fast, it's not going to have time to actually do any responses, even if it had been started on normal. That's why we don't look at it in acute hypoxia, because this baby's becoming hypoxic really fast. It's going to become really unwell really fast. Okay? In which case, no, I'm not going to wait for a scan response, because it's not going to alarm. Okay, what else?
Ahmed, let me ask them in pragmatic views. What is normal?
What is normal?
Yeah. So you did say it needs to start normal.
Yeah.
So in pragmatic views on the CTG, I just want everyone to be very clear of what do we call normal.
Okay.
So Ahmed said you need to start with a baby that is not hypoxic, because the scan is going to compare the baby with itself, with their steady normal status. So
What is normal?
when can you start that? What do we mean by normal in CTG terms?
Stable baseline, appropriate for a baby.
Any guesses?
So-
Come on, you use it every day.
So the responses we're hearing is stable baseline, appropriate for gestational age, okay, normal variability, cycling, acceleration.
That's it.
Do you need accelerations?
Yeah.
You don't need acceleration.
So we know what is
So the only
we know what is
yeah. So the
we
only
know what a normal.
So the only missing point is that you need to have enough time at the baseline. So you have a stable baseline and you're spending enough time at the baseline. If you're spending less than 50% at the baseline, that's not stable enough. Okay, so it's a normal baseline, normal variability. It's showing some cycling potentially, but that's not a requirement, because it can be active all the time, and that's not bad. But it's spending enough time at the baseline. Yeah, and then you can allow the machine to work as in, okay, carry on, look at my baby and tell me whether it's becoming hypoxic. As you correctly said, it can start alarming if there is some changes, which can happen with the baby moving, with the baby, with the bit of contact from the FSC. You need to look at when it is actually required. So we're not looking for it for the acute change, okay, or the very, very final change when baby is literally just falling off the cliff. For the preterm, we don't care about that. For the completely healthy baby, we're not looking for that. We are looking for two specific criteria. The baby that starts compensating, we're trying to make sure that it's not decompensating. So our target is not for stand to alarm. We're trying to make sure that we're not going all the way to decompensation, okay? But it also gives us a bit more of space to act before we're decompensating. We don't need to be too concerned if the baby just starts compensating. Does that make sense? And obviously, the other one is the baby that is going through subacute hypoxia, just in case I'm not actually paying attention. If I started noticing subacute hypoxia and now scan is alarming, that's obviously very serious. Yeah? So the three additional tests that we have. Charles Redmond, we've talked about it with the big caveats. We are the monitor. Yeah? Scan stimulation and when to use it. Not for the baby that has a high baseline and it's actually decompensating now, and what to look for as a response. And finally scan and when and how to use it. Yeah? Does that make sense? Okay. We did start 15 minutes late, which means that.
Ahmed, can I just summarize and comment a little bit on the slide? So would you give me just 30 seconds?
Yeah.
So in terms of the normal, it's the answer that for the question I did, there's a in CTG is all grays of all shadows of gray, isn't it? It's so what we say normal is a non-hypoxic baby, so it's a normal baseline and so stable baseline and normal variability. If you have a stable baseline or normal variability, you can start STAN. Okay, and there's a little tree to help to remind this. And if you go back on the slide, go back.
This one?
That one. So, when we teach, when we train, we tend to do things in boxes, which is good because it creates kind of framework of understanding. But real life doesn't go in boxes. There's a continuum, yeah? And when we say that there's a baby with some signs of decompensation, or a CTG with signs of decompensation, we are not saying that the baby's brain is getting ischemic and it's about to die. So there is a space that, depending on the baby, it could be to minutes to hours. That almost the babies go in a little bit of almost a hibernation stage. So, and that's why STAN is important. We want to use it. First, physiology, because we want to work to avoid STAN events. But sometimes in the very late stages of labor, to allow a normal delivery or to allow less intervention, we can trust STAN to go a little bit this gray area that on our naked eye looks like there's some signs of decompensation, but the baby, for that baby, is still fine. So this is kind of the fine tune of STAN. So most of the times we will be working to avoid STAN events and just to manage labor and hypoxic stress in a way that we have always, first thing, safe babies. Yeah. And there will be the time where you may have some signs of decompensation. If you have STAN on behind, you can trust. But this is a very, very, it needs to be a baby that is not 5 centimeters, it's 8 or 9. And you have, even though, done everything to reduce the stress if it's on Cinto, etc. Good. Just, I thought to say this because sometimes there's people panic. There's a 5 minutes of subacute hypoxia and everybody thinks that the baby's about to die. So how long they cope depends on the baby, depends on the environment, depends on many things. So it's about doing individualized cares.
Yeah.
Same way you wouldn't respond the same tachycardia. Would this person tachycardia? It's because just run down the corridor to attend the shoulder dystocia, or is because it has COVID, or is because has a tachyarrhythmia, or it's because their normal heart rate is already on the high side. So all these tools is to make us think, is not to make us brain dead, please. I know you all think.
Does anyone have any questions?
Yeah, that's good. Thank you. It's nice that everyone on CTGs.
Yeah.
Thank you very much, Humera.
Thank you,
Susanna, for joining.
How many are you today teaching? Can I ask?
So Humera is online.
Are you in a group?
There was Maya, yes, and there's 3 in the room. So we have 5 today.
Okay. So can I moan? I'm going to moan just for a couple of seconds. I don't, but I did. We have been working hard to make all these tools easy and to reduce hypoxic ischemic encephalopathy at Kingston and then hopefully everywhere. I did ask your feedback for the trees and for the cards and for the the new STAN guidelines and how are you getting on using it? And I only had 4 answers. 4.
I did respond. I
Um,
promise.
so please,
So
thank you,
everybody,
Ahmed.
everybody here.
But please,
that they
you know,
respond.
you are part. They are digging a hole, yeah? They are digging a hole to hide. I'm it's good that I'm not seeing your faces. So just to say, please, this, I know you are overwhelmed with lots of things and lots of, you know, requests, but your feedback, it's really important. We don't work with everyone at the same time. And one of the things in quality improvement is reduced variation. Yeah, it's a woman comes to Kingston, and it doesn't matter if it's 8 o'clock in the night or 3 o'clock in the morning, or 8 o'clock in the morning. They should have the same care. It doesn't matter that is a Monday or a Thursday or a Friday or Sunday. We should all, and this feedback is really important. So please, next time, please look at my emails. Okay, 30 minutes of moaning. Done.
Thank you. Okay.
Thank you. Bye-bye.
Bye.